Dr. Kosierowski is somebody that I've known, Rich, for I don't know how long, 10 years or more, and who has done me favors before and who has done the ACCP favors before in presenting us with excellent educational opportunities. And I'll let him describe his career as an oncologist. You're still with YesCare, right, Rich?
Yes, I am.
And
today, at least, yeah.
and so without any further ado, I'll just leave it to Rich to further introduce himself and talk to us about head and neck cancer and how it's
Okay. It's nice to see all of you, those who I know and those who I'm about to know. I'm Rich Kosierowski. I'm a medical oncologist. Initially started out in academics, but last 15 years or so in corrections. I also have a history of working for Aetna US Healthcare and Prudential Healthcare, as well as site surveyor for the American College of Surgeons Commission on Cancer. I wanted to talk today about the head and neck cancer. And basically, I think we've already, the goals, raise PCP's awareness of squamous cell carcinoma of the head and neck. That's number one. You got to think of it. If you don't think of it, you're not going to diagnose it. And then we're going to talk about HPV versus non-HPV, a little bit about treatment, complications, and long-term follow-up. And we'll just get going. The big thing is, it's a big area, head and neck. The symptoms can be absolutely anything. You can have jaw problems. Stanley Tucci had 2 years of severe jaw pain, saw numerous doctors before he was diagnosed. Mouth discomfort, gum discomfort, teeth, throat, headache, eye problems. All depends where the tumor is. The head and neck's a big area, connects to a lot of areas. So any complaint referable to the head and neck, think of head and neck cancer. We divide it into anatomic sites. We're going to talk just a little bit about the non-squamous head and neck cancers. There are head and neck cancers of the salivary glands, of the sinuses. Those tend to be adenocarcinomas. But for the most part, we're talking about squamous cell carcinomas of the oral cavity, larynx, and oral pharynx. The big one, the one that's epidemic, is the oral pharynx, which includes the base of the tongue and the tonsils and the soft palate. Just so you know, a lot of this is taken from the NCCN guidelines. These are accessible to anybody free of charge. You just have to sign up. And each anatomic area has its own nuances. So I'm certainly not going to go over all of those things, but it is well delineated in the NCCN guidelines, and use that as a reference. I thought we'd start with a 73-year-old white male, a case presentation. He complained of sore gums behind his molar. He saw 4 doctors. He saw his primary care doc, who didn't see anything, nothing to do. He saw ENT, again, nothing. He saw a periodontist, again, nothing. The soreness continued. Finally, he saw a head and neck surgeon, and he was diagnosed with stage 4 oral pharyngeal cancer. I think we know this patient, and it's Mike Douglas. Michael Douglas. He was diagnosed with stage 4 squamous cell carcinoma of the head and neck. He's undergone chemo and radiation and is currently doing well. Stanley Tucci is another one. He had the 2 years of severe jaw pain. Took him years before he was diagnosed with the same tumor. Michael Douglas spoke to a group of head and neck surgeons, and he says, I realized that he was misdiagnosed. It had nothing to do with not having good doctors. He had great doctors. What was missing in the equation was a simple bit of information that could have led to my doctor considering this one option, which us as specialists, it's pretty clear, but to all other doctors in other specialties, you don't even think of it. Well, now you're going to think of it. Think of head and neck cancer for any presentation anywhere within the head and neck. His tumor was base of the tongue, tonsil, squamous cell carcinoma, fairly typical. Squamous cell carcinoma of the head and neck, especially of the oral pharynx, is epidemic at this point. The oral pharynx includes the base of the tongue, the tonsil, the posterior pharyngeal wall. What's important about this is the epidemic part of it is a separate type of oral pharyngeal cancer. It's that associated with an HPV infection. And over the last 20 years, this has been increasing markedly. And it's thought that by now, HPV will cause more oropharyngeal cancers than cervical cancers in the United States. Hasn't quite gotten there by the time this slide was done, but as you will see, you can sometimes pick this up on physical exam. This would be the tonsil, but realize that this extends down to the base of the tongue where you really can't see it. You could see how Michael Douglas, who was complaining of soreness at the base of the molar, that certainly could have been from the tonsillar area that was there. So if you don't see anything, it doesn't mean it's not there. A mirror exam could possibly find this earlier. A digital exam and a gloved finger going down the back of the throat can possibly find these earlier, or just refer them to ENT if you have any suspicion. But they're there and they're actually fairly visible. But I want to just talk about HPV-related cancers because it is such a hot topic. Right now, there's 4,000 deaths yearly in the U.S. from cervical cancer and 2,400 deaths from oropharyngeal cancer. Anal, penile, and vulvar cancers are also HPV-related, at least in terms of anal, penile, and vulvar. HIV is also associated, but HPV is a major component. HPV, human papillomavirus, is a group of 150 related viruses. Counts for about 5% of cancers worldwide. Cervical cancer is widespread. Head and neck cancer is widespread. Types 6 and 11 are usually genital warts, which tend to be benign. But HPV 16 and 18 are the responsible for the majority of HPV-caused cancers. Most infections with high-risk HPVs do not cause cancer. Almost everyone gets infected with HPVs. Almost all women get HPV infections, even HPV 16 and 18. Most of us clear these infections within a year or two, and there is no sequela. However, if you do not clear this infection, within 1 or 2 years, you are at risk for an eventual malignancy. And infections that last for many years increase a person's risk of developing cancer. Hopefully, with vaccination for HPV, we will see this start to decrease, but at this point, we are still in the upward slope. In terms of oropharyngeal, and this is the most common squamous cell carcinoma of the head and neck you're going to see, it was easily the number 4 or 5 cancer that I saw back in my days in Pennsylvania, behind prostate, lung, and colon, squamous cell carcinoma of the head and neck. But there are 2 types. There's HPV positive and HPV negative. Stanley Tucci and Michael Douglas were HPV positive. I'm not saying they are non-smokers or non-drinkers, but you will see this in non-smokers, non-drinkers. They tend to be younger, have a smaller primary. It is a male predominant disease, and they do very well even with advanced disease. The old time oropharyngeal cancer is HPV negative. That's the one you see in smokers and drinkers. They have a mutated oncogene, P53, tend to be older, have large primaries, have a much worse prognosis. And here's just from one of our studies that we've done for HPV. HPV positive people have excellent survival. Out to 5-6 years, 80% survival. HPV negative, if you live a year or 2, you are lucky. So it's a very big difference between HPV positive and HPV negative. They're 2 separate diseases. And actually, if you look at the staging criteria, and I'm not going to bore you with all the staging, but they are staged differently. And basically, when we talk about stage, we talk about the T stage, and that's how big is the tumor. A T4, which is the largest tumor that you can have, HPV positive, is only stage 3. Whereas if you're HPV negative, if you have a T4, you are stage 4. So that's one of the differences. We even treat them differently. But again, the staging is different. How we define the nodes, how we define the size of the tumor is different if it's HPV positive or negative. So if you have a patient diagnosed with oropharyngeal cancer, truly the first question you're going to ask is, what's their HPV status? And here you can see the epidemic proportion. Overall, oropharyngeal slowly increasing over time, but it's the HPV positive which is increasing markedly, and the HPV negative which is decreasing markedly. And here you can see it compared to cervical cancer. Cervical cancer death rates have been decreasing due to vaccination, but the oropharyngeal is increasing mainly in men, remaining fairly steady in females, but again, it's a male disease.
Is this
And
just
again,
random
the annual
screening
number of-
data
Excuse
at
me?
a certain age?
Give me
Is
the
this,
question
is
again.
this, when were these were these just random screenings of certain age groups here that we're looking at? The HPV
These are
testing?
not screened. These are incidents of
These-
oropharyngeal cancer,
Okay, these are all known cancers. Okay, gotcha.
known cancers.
Gotcha.
Yes. So it's increasing. So it's in your system now. So let's talk about HPV positive oropharyngeal cancer. Patient's going to be 30s, 40s, 50s. They're going to be a walkie-talkie, good performance status. They may be a non-smoker, non-drinker, or light smoker, light drinker. High-risk sexual behavior, but their prognosis is going to be excellent. Again, HPV is ubiquitous. We all have it. It's easy to transmit. It really requires mucosal contact. And what this basically means is that oral sex, oral genital contact will transmit the infection. Again, most of us will clear the infection within a year or two. If you don't clear and you have persistent disease, that's when you're going to be prone to getting the cancer. We know that from the cervical model, and it's beginning to look like that for the oropharyngeal model. And this looks at the how long were you positive for HPV. Here you can see about 30% of the patients were positive for HPV more than 10 years prior to their developing the oropharyngeal cancer. So these are people who are not clearing HPV. It can be as little as 2 years, but HPV, you have it for a long time before it causes oropharyngeal cancer. Well, where do you get it? This is an interest. Yeah, Mike?
How in the world did they get that data about 10 years when that's really curious to me.
Serum from people. They had serum from people from other diseases and other studies and followed them. And when they developed oropharyngeal cancer, they went back and did
it was
the
retrospective.
studies.
I get it. Awesome. Thanks. Sorry.
This is prospective here, and this is simply taking a culture as to what's sitting on your penis. And as you can see, HPV can be cultured from just about anyone's penis, especially males. Doesn't mean that they're infected. This is a colonization on the penis. Penis is not very prone to infection because it's not a warm, moist area. But if it's already sitting on your penis and it's been put into a warm, moist area, such as a vagina or someone else's mouth, that's when you can transmit the infection. And as you can see here, 16 and 18 are certainly some of the HPVs which are there, but there are numerous HPVs. So who's causing these cancers? It's the men. We are the ones who harbor the disease and spread the wealth. Phil.
If you, let's say a patient got type 40 on this list and cleared it in a year, got re-exposed again, do they clear it really quickly? Or does, let's say somebody's just, very sexually active and they're clearing these things like anybody else does, but they keep reinfecting so much, is the net effect a chronic infection? Is that what people are noticing?
The best I can tell you is a study of women with cervical cancer. And this is not cervical cancer, but CIN 2 and 3, which is not yet cervical cancer, but cervical dysplasia. If you take those women and you just follow them and give them good nutrition, take away cigarettes, and take away sexual partners, they will clear that easily. And we see that in incarcerated patients who have had multiple sexual partners outside. They come inside, they have to stop smoking, they get better nutrition, and they have fewer sexual partners, and the CIN 2 and 3 clears itself. Whereas if they were left on the outside and getting repeated infections with other HPVs, HPV is immunosuppressive in and of itself, and you can't clear the infection, and you get a long-standing infection and eventually get cervical cancer. Does that answer that?
Yeah, that's very helpful. Thank you.
Okay, let's talk a little bit about the old standard head and neck cancer. That's what you see in smokers, drinkers, poor dentition, betel nut, poor nutrition, field defect. People with the old head and neck cancer will get a cancer here, then one will pop up there, and it's everywhere throughout the head and neck. So the entire area is infected. And the main culprits are smoking, drinking, and betel nut. But you put them all together, smoking, drinking, and betel nut, you're over 100 times more likely to get head and neck cancer than smoking alone or alcohol alone. So it's that combination of those three. We don't see much betel nut here, but certainly in some of our institutions where we might see Asian Pacific patients, betel nut is a very common disorder. And here you can see the dentition caused by betel nut. Betel nut looks much like a, what does that look like? Nutmeg, about the same size. On a cut surface, it looks the same. It's seen Bangladesh, India, Malaysia, Vietnam, very common there. And realize these are pretty poor areas. And chewing tobacco is very common. Betel nut is very common. This is a very common practice. They wrap up the betel nut with some tobacco into what we call quids. They place that quid between the gum and mouth with tobacco, some lye, some Zarda, which is a form of chewing tobacco. And they keep this in there, and it gives them the nicotine high that you would get from cigarettes at much less the cost, but it also causes severe problems with head and neck cancers. And that's why one of the things we really need to do is to make friends with your dentist. At least for the old type of head and neck cancer, you're going to see it in the mouth. Your dentist is probably much better at looking at these, but everyone should be looking in there. We don't just look to see if the tongue is midline or the tonsils are symmetrical. We should really look at the mucosa. Here you can see an early squamous cell with the classic keratin pearl. That's pathognomonic for squamous cell cancers. This is one of the tongue. Again, this can be picked up by anybody, but your dental colleagues are probably better doing oral exams than we are. If you have a head and neck cancer, whether it be HPV positive or HPV negative, you need to make sure you get a dental evaluation, because more than likely these people are going to get some therapy which is going to make their mouth worse. So there's a list of things the dentist has to do. PET scanning is very good for this because it picks up nodal involvement. And certainly if you can pick up a tumor when it's unilateral, it's much easier in the patient than if you have bilateral disease. But the therapy for this disease is going to cause swallowing dysfunction, and these patients are already going to be nutritionally compromised. And then with therapy, nutrition is going to become even worse. The therapy for this disease is very hard on the body. You need adequate nutrition. So a lot of the therapy is going to be pre-therapy by making sure the patient is optimized. Dentist has a lot to do. Number one, make sure there's no dental caries, because if the patient's going to need radiation, they have to have dental extractions before the radiation for at least 2 weeks to allow it to heal. There's going to be xerostomia from the radiation and from the chemotherapy. They may want to add in some fluoride therapy to strengthen the teeth, but there's a lot for the dentist to do. And actually, NCCN has a good page here just for the dentist. That's a checklist of what the dentist has to do before therapy even starts. This is dry mouth strategies, dental caries prevention, topical fluoride, taking care of the muscles so that you don't get a trismus afterwards. A lot for the dentist to do. 2 pages of it. And again, I give this to the dental colleagues, make sure that if there is a head and neck evaluation, that they go through all this and document it pre-therapy. The other thing I need to do is to address the nutritional management. Again, these patients, if they're HPV positive, they're usually in pretty good shape, and this isn't going to be a problem. If they're HPV negative, they're already nutritionally starved. And we know that head and neck cancer can cause swallowing dysfunction. So relying on oral intake can be dicey. It may not be something you can do. You need to have formal speech and swallowing evaluation, because you're going to need to maintain nutrition during the entire course of therapy. And the course of therapy is going to further diminish swallowing function and speech function. So nutrition is going to become even more important. So these are just some of the things. Basically, if there's a 5% weight loss over 1 month or a 10% weight loss over 6 months, we recommend the prophylactic feeding tube, because you're not going to maintain your nutrition during therapy. Therapy causes severe mucositis. The chemotherapy causes severe nausea. These patients already can't swallow well. Feeding tubes are necessary. And this just goes to show that, to remind everybody the mechanism that we have, which is a very tight mechanism. I'd ask everyone right now to start taking a deep breath in through your nose. And as you're taking that breath in through your nose, I want you to simultaneously swallow. Do it now. Deep breath in and swallow. You can't do it. And it's meant to be that way. You can't both breathe and swallow at the same time, unless you have a head and neck tumor where your epiglottis and your soft palate are not acting well, or after radiation, where due to swelling and fibrosis of your epiglottis, of your soft palate, you're going to disrupt that mechanism for swallowing and for breathing. And so that's why these people will have lifelong problems with aspiration. And you need to look at that not only during therapy, but also after therapy, going to be a lifelong problem. So the prophylactic feeding tube, we talked about the parameters, 10% of the weight or 5% over 1 month. But anyone who looks bad, severe weight loss prior to therapy, those with dysphagia, dehydration, anorexia, or pain are going to need it also. Anyone who has significant comorbidities that may be aggravated by decreased intake. Aspiration is going to be a problem lifelong, and these patients will likely have lifelong swallowing dysfunction Again, a swallowing evaluation, a speech evaluation is probably going to be necessary for every patient with squamous cell of the head and neck. Want to move out to some of the other tumor types in the head and neck just to mention them. And first, we're going to talk about the nasopharynx. And that's up here, and that you really can't see. With a good mirror exam, you can maybe look back up, but it's not going to be light enough for you to see it. You really need a fiber optic scope. This can be visualized, but nasopharyngeal is important. These tumors are going to cause maybe headache, maybe hearing loss, strange sort of symptoms. What's important is that this is one of the few head and neck cancers which tends to metastasize. It's the most likely to metastasize. It's most common in men. It's really only seen in southern China, Southeast Asia, Eastern Asia, and Northern Africa. It's associated with Epstein-Barr infection, which causes the cancer. Whether it's as clean as the HPV-related data, it's hard to say, but certainly EBV is associated with this, and it's a disease where the metastatic disease is probably more important than the primary disease. The other important one is larynx. This is, the voice box, and you have all those stories of the people who are smoking who get laryngeal cancer. Definitely smoking and drinking related. It's a different disease if the tumor is up here, or if the tumor is down here, or on the vocal cords themselves. You're going to want to see the mobility of the vocal cord. This, like many head and neck cancers, can be treated either by surgery or radiation. But cancer of the larynx is important because it tends to present somewhat early, especially if it is on the larynx. They're going to have a hoarse voice. You can see this tumor. And this is something where surgery might actually be the easier of the therapies because there's less long-term damage. And certainly if your patient is employed as either a singer or anything with speech, the quality of speech is probably going to be better after surgery than it would be after radiation. One of the things you always look at when you do a CT scan is if there is invasion of the thyroid or cricoid cartilage, you are really not a candidate for radiation because radiation does not work well in areas that do not have good oxygenation, and cartilage is known not to have good oxygenation. So it rules out surgery, and those are the patients who need to go to laryngectomy. So again, you can see this. Again, you can do a mirror exam even in the prison, but few of us are very good at that. You can see the nodularity here. This can be stripped off. You can find this early. Certainly a change in the voice, a hoarse voice. You think about laryngeal cancer. You think about a centralized lung cancer, getting the recurrent laryngeal nerve. Both of them need rather immediate attention, and you can actually have a very good outcome. And this, again, just shows some of the surgical outcomes that you can have. Salivary gland tumors are pretty rare, but I mention them because it's something we call NTRK. You see here, that a lot of these can be seen in patients who've had very strange tumors in childhood. There are rhabdomyosarcomas and some of these other big, long names, because we find out that a lot of these childhood tumors are caused by a specific gene rearrangement that is called NTRK, and that can now be treated with oral medication if you think of it. So you always have to have these tumors sent out for a very specific gene assay to see if it's NTRK. Otherwise, salivary gland tumors can actually respond to anti-androgens, and sometimes we use Lupron on these people, or sometimes they can be treated like breast cancer because they express HER2, which is the common thing in BRCA and other breast cancers. So sort of a strange grouping of tumors. Usually these are painless masses on the salivary gland. Many are benign, but again, they can be malignant and they need to be just thought of. Melanoma can actually occur in the head and neck. Again, this is rare, and the melanoma is not in a sun-exposed area. Usually, head and neck melanomas arise from the nasal cavity and the paranasal sinus region. So these are just some of the strange things you can see. Most head and neck cancers are squamous cell, but certainly mucosal melanoma, salivary gland tumors are the exception, but you need to at least think of them. Which leads to, what do you do when the patient presents with a lump in their neck? This is a very common presentation, and it's treated so many different ways. And here's what NCCN, well, first you want to try to identify where is it in the neck, because if it's a supraclavicular node, you will treat it a little bit differently than if it's a posterior auricular. Most of these are going to be in the cervical chain. Submental ones are usually from the oral cavity, so you can get some idea as to where the node is, but they're not 100%. NCCN says if you have a neck mass, you do a complete head and neck exam with palpation of the oropharynx, mirror and fiber optic examination to examine the nasopharynx, oropharynx, hypopharynx, and larynx. So ENT exam is the first thing you do. The second thing you do is an FNA, because as we mentioned, head and neck cancers are not always squamous cell, though that's the most common, but they can also be a lymphoma, a thyroid cancer, or a melanoma. So if you have a neck mass, the wrong answer is you get a CAT scan. I don't care where the other nodes are. I want to know what's in this node. I want to know, is it squamous cell or one of these other strange ones? So do a head and neck exam. The ENT doctor can then do an FNA in the office. Once it's squamous, then you can go and do the appropriate imaging studies. But to just to put the patient on antibiotics or to schedule an imaging study is probably doing the patient a disservice. Do a head and neck exam, get tissue so you know what end of the spectrum you're looking at. Once you're completed with therapy, it's going to vary again if you're HPV positive or HPV negative. Right now, we follow all of them the same, but probably HPV positive patients will have a much better course and don't need as much surveillance. But for the HPV negative people, you need an ENT or a radiation oncologist to do a cancer-directed direct visualization that's fiber optic, looking at the larynx, looking at the nasopharynx, looking at the oropharynx, because head and neck cancers, the old type, it's a field defect. So just because you had one cancer, you're very prone to having a second cancer somewhere else. So direct visualization is what you need, not imaging. At the end of therapy, everyone's going to need a PET scan. And once you're PET negative, that should be it for the PET scans. There is no need for additional imaging unless there are suspicious findings on history or physical exam. So sending the patient out for a yearly PET scan or a yearly CAT scan is not what NCCN recommends. If the patient has specific findings on exam, either on direct visualization or with symptoms, then imaging might be appropriate. But basically, these patients will be seen by ENT every 3 months for the first year, every 4 months for the second year, every 6 months afterwards, and then probably yearly after that. Surveillance does not have to involve routine imaging unless there's a specific problem. So another case, a 60-year-old male who initially had a papillary thyroid cancer, which was resected. He then developed a salivary gland tumor at age 81. He had radiation to the neck for the salivary gland tumor after resection. At age 65, he had a jaw recurrence, which was resected. During the resection, he had a carotid artery blowout. Realizing that in an area that's radiated, you really don't want to do any other manipulation. That carotid artery is tenuous if it's been radiated. This patient had a very severe case with the carotid artery blowout. He was eventually salvaged. He had a feeding tube, but he was left unable to speak or swallow, and he expired at age 70. You might know this as Roger Ebert, the movie critic, who this was him in his heyday with Siskel and Ebert. He developed those cancers, and then he was left like that. Tremendous disfiguration. Here was a man who was known for his reviews of movies, and now he couldn't speak and he couldn't eat. So certainly depression is certainly something that happens also. This is disfiguring. He lost his ability to taste. He lost his ability to smell. It's a devastating disease. Well, just a word about treatment. Number one is surgery. If you can do it, fine. Surgery is probably the least morbid of all the things we're going to talk about, but head and neck surgeons are hard to find, and it's a tough operation. Other than that, radiation and concurrent chemotherapy is probably the standard of care. But that's toxic, and it's going to have long-term side effects. But you can cure this disease even if it's stage 4 with aggressive therapy. The chemotherapy is classically cisplatin, cis-diamino dichloroplatinum. The things to know about that: highly emetogenic, renal toxic, neurotoxic, ototoxic, neurotoxic, a very bad agent. And not a very good agent if you're worried about trying to keep someone's nutrition up, because they're not going to feel like eating. They're going to get radiated. They're going to have severe mucositis. On top of that, they're going to be nauseated. So getting a patient through therapy is going to be a challenge. But you have to keep the patient hydrated because cisplatin is so toxic to the kidneys. If you don't keep them hydrated, you end up with someone with renal failure. This is just a radiation field. Radiation is very confining. You can imagine that, a patient who's at risk of aspirating has to lie still on a flat table. Aspiration is something that can happen. You can just imagine what happened if you have a severe sinus infection or even a bad cold. You can't breathe like that. It's tough on patients. And just a few more things. These masks are custom designed for each patient, and they stay in the same position. Usually takes about 35 treatments. However, if HPV positive, it can be down to 25 or even 20 treatments. Within that zone of radiation are all of your salivary glands, the parotid, submaxillary, sublingual, all being hit with radiation. They're all going to be killed off here. It's important to diagnose the tumor early because hopefully you can just get by with unilateral radiation and spare the contralateral side. However, if it's bilateral, you're going to have problems. You're going to lose your ability to taste. If you can't taste, you won't be able to smell either. Food sensations are going to be much different. After chemotherapy, you have the same sort of thing. Put the two of them together. Then you get tissue fibrosis and scarring. Again, that's going to affect your ability to speak, going to affect your ability to breathe and to swallow. The long-term effects of radiation are forever. Luckily, the hair loss is going to be minimal in this area. You only see the hair loss in the area that is radiated. But what we do to the salivary glands is going to affect a lot of things. You're going to get a dry mouth. When you have a dry mouth, you don't taste. When you have a dry mouth, you get dental caries, you get thrush, and you get dental caries and gingivitis and bleeding. Going to make following this patient very difficult, devastating and life-altering symptoms. And you can see even more effect, all due to the xerostomia. This is all benign disease here. This is caused by the therapy. So your dental colleagues are going to need to be involved early and often in long-term follow-up. And just a few more. Hope you had your dinner. Okay, all of this is due to xerostomia. and realize that the patient's also going to be pretty depressed. So you can have them on antipsychotics. Antipsychotics cause xerostomia also. You're already knocked out their salivary gland. The chemotherapy did some of this too. The radiotherapy did a lot. So your mouth is going to be a mess. If we can avoid chemoradiation, we will do well, but it's a curative therapy. So we tend to put up with the side effects. So xerostomia is just the oral dryness. Just having the dry mouth is very bothersome to most of the patients. And they're going to complain about that. Giving them some oral mouthwashes, non-alcohol containing, obviously is going to be important, but there's not a good thing for that. Again, the taste buds are in that same radiation field. You're not going to taste anything. And even though prison food is not the most palatable, if you've had radiation, it's all going to taste like the same cardboard. So the treatment is usually surgery. If you can do it, fine. But again, radiation and chemo is where you're going to probably be. There are also biologics that we use at times. And then there's the immune agents, which hopefully are going to take over a lot of the therapy. The immune agents, I'm sure you've heard about. We'd like to talk about the PD-1 blockade or the immune checkpoint inhibitors, the Pembro, which is called Keytruda, nivolumab, durvalumab, tislelizumab. These are very effective immune agents. Unfortunately, the immune agents up front do not cure squamous cell carcinoma of the head and neck. And the reason is because we were stupid when we first started using them, because we simply added it to chemotherapy and radiation. Well, if you add an immune stimulatory agent to radiation, you get all of these immune prime cells, and then you killed off those cells with the radiation. So it didn't work. But once you've completed radiation, these immune checkpoint inhibitors are fairly good in terms of relapse disease. Well, we're moving it up the front line, but right now these are mainly for relapse disease. And it's important to realize how these drugs work. We talk about PD-1, PD-L1. There's a CTL4. This occurs in the lymph nodes. This occurs in the tissues. Not too important. But what's important is that the T cell has an emergency shutoff switch called PD-1. And the cancer cell has learned where this emergency switch is, and it developed PD-L1. And when PD-L1 hits PD-1, the immune system is turned off. So by blocking either PD-1 or PD-L1 and stopping this union, the immune system gets turned on. And it's that immune system which can then kill off tumor cells. And we're using immune checkpoint inhibition to treat lung cancer, every cancer. And it's the most common chemotherapy at this point, even though it's all immune therapy. Very well tolerated, but there are autoimmune effects from these things, very expensive. But the immune checkpoint inhibitors definitely play a role in relapsed or refractory squamous cell of the head and neck. But they're very expensive. They're at least $100,000 a year, and therapy goes on for 1 or 2 years. However, there's a glimmer of hope. And this is a study, probably not important, but it was a head and neck study, and it was from India. And again, India is where the betel nut is. That's where you get those really bad squamous cell carcinomas of the head and neck. India is not your richest country. They don't have a lot of radiation facilities. So all they treat people with is chemotherapy. And they can't afford Keytruda or Pembro. So what this guy did is one of the, much like Keytruda, is nivolumab. And the usual dose is 240 milligrams. He gave a tenth of that dose, 20 milligrams, to his patients, because that's all they could afford. And at a dose, at 1/10 of the dose, he saw a marked difference in survival with low dose immunotherapy. Now, this study was suppressed by the drug companies, obviously, because they don't want us using 1/10 of the dose of their medication. But this has started a mini revolution in terms of at least thinking about de-escalating the dose of immune checkpoint inhibitors. And maybe by using these agents, we can get better access in third world countries, but maybe even better therapy for our patients. So the goal was to make you at least think about head and neck cancer. Hopefully I did that. I wanted to show you how toxic the current therapy is, and certainly with radiation and chemo, you've seen that. And I wanted to make sure that you include in your workup the dental, the nutrition, and the long-term follow-up. These patients have long-term problems. So hopefully you'll take this out, and squamous cell carcinoma of the head and neck will be something you will diagnose much better than we did with Michael Douglas or Stanley Tucci. And that's all I have. The first reference is New England Journal on HPV disease in the head and neck. And the second reference is the NCCN Clinical Practice Guidelines. I'm available at any time if any of you have any questions, and I certainly thank you for your attention.
Thank you. Charles has a question. I have a question.
All right.
Oh, Charles.
First, I would like to thank you. That was an excellent presentation. It made me aware of things that I was not aware of. A couple quick questions. Now I understand why the dentist keeps sticking his finger in my mouth. I was wondering what he was looking for, but now I see what he is doing. Now I can appreciate it. One question is, should I go out and get an HPV vaccination? I've never had one.
It is currently FDA approved, I think, up to the age of 55, and you certainly look like a young man, so I see no problem not doing it.
Well, I think we can skip that question now that it's up to 55. The other quick question, he says drinkers, heavy, and I'm assuming you're talking about heavy drinkers. And a heavy drinker is defined by anybody that drinks more than I do. But in seriousness, when you say drinkers, are you talking about casual drinkers or moderate or heavy or all of the above?
Oh, I wish I really knew the answer to that. And are we talking about beer, wine, or hard stuff? Yeah, I just don't know. It is a risk factor. How much of a risk factor, I don't know. I wish I had a better answer, but drinking and smoking are associated with it. I'm not aware of anything as to vaping being associated with it, but all good questions. To outline your other, yes, everyone who is FDA eligible should have HPV vaccine. Do I know it's going to make any difference? No, but at least it'll stop spreading the disease, hopefully. And even more important, there's an experimental messenger RNA vaccine against one of the proteins that HPV produces that actually has therapeutic effects. And we may not even need checkpoint inhibitors or radiation and chemo. This messenger RNA is really looking very promising in terms of therapy for head and neck cancers. So when you can, certainly vaccinate. Certainly as a leader in the community, vaccination rates are still pitifully low in many areas. Younger people should be vaccinated.
That's not been one that I've been able to get widely approved, at least here in Wyoming. It's costlier than some of the others, I guess, but are you seeing that elsewhere where it's offered uniformly like Hep B vaccines?
Yes, and there may be reason for waiting because, I think the current vaccines take 2 or 3 doses, and there's plenty of evidence that 1 dose may well be adequate. Again, getting that information out through the drug companies is like pulling teeth, but there is good data in third world countries that a lot of protection is seen with a single dose.
You said that finding a good.
Oh, sorry.
That's my last one.
Go ahead.
You said finding a good surgeon is hard, and I would agree with that, certainly in Wyoming. And I wondered if that was just our problem or everybody's, because we've had several patients with head and neck cancers that I thought surgery would want to handle. And it seems like routinely they're saying, go see the university surgeon, go see the university surgeon. So maybe that's not just us. Do you see that all over?
Yeah, it's all over. And the other part of that is that, head and neck surgery is very delicate. Doing a radical neck dissection takes a lot of time, and the reimbursement is pitiful from Medicare. So that people aren't going into the field because it just doesn't pay. So there are a lot of problems about it. Most the head and neck cancers you see in the community can't support a practice. You need to be in a large urban center, and that's where you see the best head and neck surgeons.
Michelle?
Yeah, I was going to comment on the heavy drinking. I just looked at, I don't know what it was, a Medscape article or something earlier today where they talked about more than 14 drinks a week was considered heavy. I think someone put something in the chat in the interim.
Yep.
Yeah, 5 more drinks in the same case, about 2 hours. So I guess maybe binge versus heavy versus both. But a couple of comments. I try to encourage, I have juveniles, so I certainly encourage them to get the HPV vaccination. And in the community, we had such a difficult time convincing parents of getting kids HPV vaccination, because initially it was specifically around, preventing cervical cancer and the oral pharyngeal cancers, et cetera. And then people did not want to accept the fact that their children were sexual. And so a lot of the advertising now has changed, and you don't hear the specifics of what it's being offering protection for. But I was curious as to why the predominance of males in both the HPV negative and the HPV positive cancers. Any thoughts on that?
Well, my only thought would be, if a woman's going to have persistent HPV, it's going to more than likely be from the cervix. So we exclude those women. And yes, there are women who are exposed oral sexual wise to HPV, but maybe they built up immunity from that. But no, I don't have any good answers. I'm just making some guesses. Some of it may also be that, smoking and drinking at least used to be less common in women, maybe not so much anymore. But the other fact about all this is it's not just smoking, drinking, and sexual activity, but how young, how often, and for how long. And, if you have a young person, they have the most sexual partners. If you start drinking early, you may not make it to the 60s or 70s due to other reasons. So, yeah, I don't know how to define any of these risk factors, but the people just need to be aware of it. And I don't really have a good explanation as to why we don't see HPV oral cancers in women at this point.
Yeah, it's interesting. I know you said that the HPV colonized the penis more. Nothing with regards to, I guess, the prevalence of the colonization with the women, surely with the cervix. And most folks are doing the HPV testing for women, young women now. So it's just really interesting. I don't know why either.
The HPV testing in women, though, is pretty much just 16 or 18. If we were to test for all 150, I'm sure, every woman would have 20 or 30 of them, right? Yeah.
And for
Maddox,
reference,
did you have a question?
No, I was just going to say that information on heavy drinking and binge drinking, I put that up here. It's from the American Society of Addiction Medicine board review course.
Cool.
So I thought you might find that interesting.
Yeah, thank
Appreciate
you.
that.
I can just say my experience. I ended up with when I was working in Oregon with many people from across the state who would come to Salem for their treatment for this, and I could tell you it's hell on wheels. The the treatment and trying to get people to stick with the treatment and treat especially the mucositis and the xerostomia. It was very difficult. And you've got to have a very dedicated patient, and I think it's really important to warn them ahead of time. And I think that this is a really good topic for us, only if only because it's prevalent in our population, and the treatment is so difficult in somebody who's going to be incarcerated throughout it. Although at least the healthcare is readily available and right there for them.